everyone, welcome and thank you for bearing with us through our technical challenges here at the start of the webinar. Just when we think we've seen it all on Zoom, there are still surprises to come, but we're so glad to have each of you joining us today. I'm Rachel Hall-Clifford, co-chair of the Women in Global Health Georgia chapter, and I'm a medical anthropologist based at Emory University. So on behalf of our chapter and our co-sponsors for today, the Task Force for Global Health and the World Affairs Council of Atlanta, we're delighted that you're here. Please feel free to introduce yourself in the chat so that you can see who else is here and interact with each other. Women in Global Health is a global movement committed to women's leadership and equity in global health, and our Georgia chapter is dedicated to building community among our Georgia global health workforce. Our event today is VaxToTheMax, Lessons Learned and Opportunities Found for Increasing Global Vaccine Equity. Here we'll explore the roles high-income countries should play in equitable vaccine delivery, and we're very pleased to be featuring Dr. Rebecca Martin, who will be followed by remarks from Ms. Amanda Bolster and Dr. Stephanie Adams. So it's my pleasure to introduce you now to Dr. Rebecca Martin. Rebecca Martin is the Vice President for Global Health and the Director of the Emory Global Health Institute at Emory University. She leads efforts to foster interdisciplinary global health research and works to build the next generation of global health leaders. Prior to joining Emory, she served as the director of the Center for Global Health for 6 years at the CDC. Dr. Martin has over 30 years of experience working in international health, addressing reduction in morbidity and mortality globally. Between 2008 and 2011, Dr. Martin was detailed to the WHO European Regional Office as the regional director for immunization. And then from 2012 to 2016, Dr. Martin served as the director of the Global Immunization Division, leading CDC's global polio eradication efforts, accelerated disease control for vaccine preventable diseases, and introduction of new and underutilized vaccines, as well as strengthening of immunization systems. So I cannot think of a better person to guide us through the conversation today on promotion of vaccine equity. So with that, I will hand over to you, Dr. Martin. Thank you for joining us.
Thank you very much. Okay, I'm going to share my slides. Are they sharing?
Yes.
Okay, and then I'll do this one and display settings. All right, there we go, I think. Am I good?
Perfect. You're perfect.
Thank you very much. And first of all, a very big thank you for the invitation to be here with you today in this very important topic, and really excited to have this discussion and look forward to the discussants as well. I think this is a really, right now, very timely topic, but not only for the moment now, but for the future. And in discussing today, I am going to focus on COVID vaccine equity, but this does pertain and thinking about the future of what we do for vaccines. And I'll refer to that a little bit during the presentation as well. So today I want to talk a little bit about what do we mean when we say vaccine equity, and currently who has access to COVID vaccines. How effective are the different COVID vaccines that are currently being used globally? How much do the current vaccines cost? And that varies by country and by organization and by manufacturer. What solutions have we been able to put into date for vaccinations? What will be the requirements for vaccine distribution? And how will we go about ensuring COVID vaccines can be manufactured in LMICs? And this does have a longer term impact in thinking about future vaccines as well for upcoming diseases we don't know about, emerging, but in addition, things that we may want to think about in the future for access. And lastly, just to close, to bring it back a little bit to other great leaders in global health who have focused on health equity and what they have done in their work as well. So if we talk about vaccine equity, why should we care about this? And it's not just about global vaccine equity and justice. This is not just an issue of public global good or fairness, but we know that with COVID, with SARS-CoV-2, the more the virus circulates around the world, it has time to mutate, create new strains that will continue to threaten the entire world anywhere as long as it exists in the world. So this is incredibly important in thinking about that we do need to make sure that everyone has access to COVID vaccines everywhere. And what we saw was incredible, the lightning speed work that was done to develop the vaccine and get emergency use listings and approvals was never had been done before in the world of global health and responding to a pandemic. And making sure that there were safe and effective COVID vaccines is only the first step. If we think about how then are they fairly distributed to populations, and that means all regions of the world, all people of any type of means and backgrounds, how do you ensure they have access to them? And then once a vaccine is in a country, how do we ensure, again, access, equitable access to vaccines? And that requires that there were guidelines. Who was going to get the vaccine first, prioritizing people at high risk, thinking about different populations that could have higher rates of mortality. And then this has to be implemented in a country as well, and thinking about that. And as well, we know even in the United States, but around the world, if we compare rural areas or areas that may have as not equitable access to healthcare, making sure that there were freezers that could go below sub-zero to be able to have vaccine and distribute are also issues of equity, of ensuring that we can make sure we can reach populations. So to talk a little bit about who has access to COVID vaccine, these are data from our World in Data as of May 9th. And looking here, of course, the darker blue are the number of people who completed the initial COVID vaccine protocol per their country. And the darker blue means more people vaccinated along the scale at the bottom. And of course, you can quickly see that the Africa regions do stand out here, as well as parts of Southeast Asia as well. And so the importance here of looking and understanding who does have access to vaccine. 65.5% of the world's population has received at least one dose of COVID-19 vaccine. Over 11.5 billion doses have been distributed globally, and currently nearly 9 million doses are being given daily across the world. But if we look at that, only 15.9% of people who live in low-income countries have received at least one dose of a COVID-19 vaccine. This is then looking at boosters, which even shows greater disparity here of how we see boosters being used per 100 people as of May 9th as well. And if we look, the top countries that have been delivering boosters are actually South Korea, Italy, Japan, Germany, France, the UK, Brazil, Israel, Thailand, the United States, Turkey, and Russia. And again, none of them are in the African continent. So in the absence of vaccines, some countries, of course, all of us took to non-pharmaceutical interventions, thinking about safe distancing of 6 feet, of ensuring wearing masks, and making sure that we can continue to implement these measures to mitigate the risk. But again, this is not the only way. In addition, vaccines are not the only way. We need a mixture of both the non-pharmaceutical interventions with access to vaccines and, of course, treatment as well. If we look at the effectiveness of the different COVID-19 vaccines, we have seen to date that the mRNA vaccines are the most effective of the COVID vaccines in protecting against Omicron where they are to date. And we have learned that boosters are incredibly important to protect the population and add some protection as well. And we have seen that globally, though, nearly half of all the vaccines that have been given globally by November 2021 were made by Chinese manufacturers. And the data currently to date on those vaccines are that they are less effective. That doesn't mean that they shouldn't be used, but we recognize that there will be continued spread In addition, that the importance of getting vaccines out there, no matter of the level of effectiveness, it was important that we have vaccines being used. But we recognize that the mRNA vaccines, while being most effective, were not equitable and not access to everyone that needed them. Also, if we look at the cost of COVID-19 vaccines, this is just a quick snapshot from 2022, looking at the Pfizer, BioNTech, Moderna, and Johnson & Johnson. And I highlighted here in yellow, as you can see, the difference in what countries or groups of countries, for example, the European Union, are paying for a dose of COVID-19 vaccine. And it ranges when we look at Pfizer, BioNTech, the US and the EU paying $19.50, Africa Union paying $6.75. When we go to Moderna, you see Botswana here paying $28, and the EU and the US paying $15 and EU paying $25. So again, you can see the difference that is there in terms of how contracts are made and how agreements are made to procure vaccine. We have seen the variance range from $2 per dose to $40 per dose, according to data from UNICEF. So what are some of the solutions to COVID vaccines to date? And I want to talk a little bit about COVAX, which was formed as a global collaboration with Gavi, the Vaccine Alliance, the World Health Organization, and CEPI, which is the Coalition for Epidemic Preparedness Innovations. And their goal was to secure at least 2 billion doses by the end of 2021 and ensure equitable access to 92 low and middle income countries. And important to note, they were only going to provide 20% of what was needed for an entire population in a country. So it's not a way to procure a vaccine for an entire country. It was for 20%, and then thinking about the guidelines that needed to be implemented, how that vaccine would be utilized in country. The important, I think, is to date, what we've seen is that through COVAX, 2.8 billion doses of vaccine have been secured or received as donations. So they have that many billion doses of vaccine, and nearly 1.5 billion doses have been shipped to over 145 countries. So this is starting now. It was supposed to start quite much earlier, but we'll talk a little bit about why that didn't happen. But the importance is that there is now this global collaboration, but it is really focused around one vaccine, COVID-19 vaccine, and how to distribute it. I want to spend a little time talking about, so as I mentioned, vaccine equity. So having a safe and effective vaccine is critical and is important to be able to move forward, but it's not enough. We have to ensure that the vaccine can be distributed in a country, make sure we're getting vaccines into arms, and make sure that populations are being able to get vaccinated. And there's a lot of steps that go into that. So even having vaccines, we see that there are still barriers to equity and to being able to make sure that everyone who needs COVID-19 vaccine could get one. And I'm going to go through at least 5 of the top factors to be considered here, but there's a lot more depending, and of course there's tailored solutions for each of the countries that need to address these issues. So first, of course, is the workforce. We have seen that this is a vaccine that needs to be injected, so it does require a healthcare worker to do that. And we have seen, as you can see here, the numbers, the lack or the dearth of healthcare providers to actually vaccinate populations. And again, when you look at this by geographic distribution within a country, you will find most of these healthcare workers in urban settings and not the rural settings. You'll find even more disparity in that. And this is an important factor in thinking about how to roll out COVID-19 vaccine. Secondly is the cold chain. I mentioned briefly that for Moderna and for mRNA vaccines require a sub-zero cold chain, and so sub-zero freezer. And so having these cold chains that are existing, that are reliable with electricity, and having the specialized technicians to be able to sustain and maintain these cold chains is critical. And this is another area where we see that without having this expertise constantly, as well as having access to it, is another barrier to making sure that we can ensure vaccination for everybody that needs it. The third point I wanted to talk about is the communication, the myths and disinformation that we have seen, as well as vaccine hesitancy. Hearing about some of the vaccines and seeing what had happened, news traveled quickly and countries decided we don't want X vaccine, we will wait for Y vaccine. And so the information again is how do we get ahead of ensuring that the communications, that there is awareness, the information is shared on a timely basis, and that again, the importance of working with community to be able to make sure that they value and demand vaccine vis-a-vis not wanting to be vaccinated, and the importance of how that is done over time. And doing that during a pandemic or an epidemic is very hard and does require long-term work on this for the sustainability of the importance of the health. The last two I wanted to refer to are talking about vaccine supply management. And we saw this, some countries received vaccine through COVAX and vaccine expired in a week. And they were trying to move, countries were trying to move vaccine to remote areas, to other parts outside the capital, and were not able to do this in a week's time. And so some vaccine was not able to be used that had been sent to countries. And then thinking about the right number of doses per area, who's going to be vaccinated based on the risk populations. All of this has to be thought of ahead of time and planned for, and requires data on a regular basis to be able to do this. So this is very critical in thinking about this step, because without this, you can have all the vaccine, but if you can't deliver it, keeping it in its right temperature so that it's still effective, that you have the healthcare workers that can vaccinate, a community that wants vaccination, and the right number of doses. All of these have to come together and can be barriers to equitable distribution of vaccine if not addressed or in place already. And lastly, which is really critical, is about the data. Having the right data at the right time to know what is happening with COVID, what's the burden of disease, what's the epidemiology telling us, who has died from COVID, who's most at risk. So many of these points are very critical in this front. And we saw both South Africa and Peru, their estimates of excess deaths were 3 times what has been reported. And India noted that only 10% of their COVID deaths were officially reported. So again, the importance of this. And then lastly, the value of knowing when we're vaccinating, if there are adverse events following vaccination, how are these being handled and reported? Because addressing these quickly and effectively in a professional manner is very important, or can actually lead to more mis or disinformation. So all of these are important components coming together. The last area I wanted to talk a little bit about is, we've talked about COVAX being a global coordination facility to deliver vaccines. But in the long term, how do we ensure that vaccines can be manufactured in low and middle income countries? And this is more complex than I can even pretend to know about this, because the more I dig into this, the more I learn. There are just so many issues, especially around the world trade and agreements. And this is really important in thinking about all of this. There's been a lot of work on this. There is still not a solution to date, but the current international intellectual property rights of vaccine manufacturers do not allow COVID vaccines being produced outside of the global north to date. The most strongest agreement that exists globally is TRIPS, which is the trade-related aspects of international intellectual property rights, which was established in 1994. And this is the most comprehensive and agreement that exists, but in addition, there's been many efforts over the time to address this that have not led to any progress or success. Currently, the US, the European Union, India, and South Africa are working on an outcome document to allow third-party manufacturers to produce patent-protected COVID-19 vaccines. And this will be presented to World Trade Organization members, 164 members, excuse me, in June of 2022 at the conference. So this is moving towards sort of a progress on this, but do note this is only for COVID-19 vaccines. This is not for COVID-19 treatments or for any other vaccine. So it's a very specific targeted outcomes document that they're working on with the World Trade Organization. In addition, there is no global legal framework to regulate research and development, manufacturing, procurement, and allocation. So all of these issues that are needed to be done on a global level to bring people together are still underway, and there's been a lot of effort to do with this. Also, we need to make sure, as LMICs think about manufacturing, that the good manufacturing practices, GMP, have to be in place, and there has to be high level compliance with this, and not just at a one point in time, but over time. And that's where we see around the world where some manufacturers have problems with GMP at a particular point in time and have to go through to get compliance again, to get regulation. So these are really important. And then lastly, to note that tech transfer does take a lot of time. And I know we have Dr. Stephanie Adams in the discussion who I hope will address some of this. But again, the importance of this and thinking about it's not something you do during the pandemic. I mean, we need to work now for the future because there's no better time to start this important critical work. I want to talk a little bit about with manufacturing and thinking about what COVAX, we have this global coordination, but there are some specific points of COVAX that have not been addressed in thinking about manufacturing vaccines in low and middle income countries. First of all, COVAX provides the financial advantages purchasing vaccines to the pharmaceutical companies and not to any low and middle income countries at this particular point in time. Again, it is disease specific. It is for COVID-19, and it is a market solution that's been made to address a pandemic. Again, so thinking long term, there is still much work to be done on this. There are no incentives for research and development for vaccines for low and middle income countries. It does not address the intellectual property rights, which I've just talked about through the World Trade Organization. And there is no mechanism to ensure that pharma provides the doses to LMICs instead of high-income countries or other countries which may manufacture COVID-19 vaccines. And one example was in 2021, when India was facing a dire situation with COVID-19, India government stopped the exportation of the vaccine that was being developed by Serum Institute of India. And again, fully, understanding where they were, what they were trying to do. But again, this was supposed to go to the global supply to go to other countries. And again, there is nothing there that COVAX could do to address that issue in that particular point in time. And lastly, that once vaccines are in country, making sure that they go to the most vulnerable, the most high risk early on is something that still needs to be addressed. And that is not something that under COVAX's umbrella of looking at this particular point in time. The last remarks I wanted to make on this are why don't we just take publicly available formulas for COVID-19 vaccines and manufacture vaccines in low and middle income countries? And this is what South Africa did. The Biologics and Vaccines produced mRNA vaccines based on publicly available data of Moderna's vaccine. But there are other factors that come into play in this. And first of all, there is a large effort which has been there, but never to the level needed to strengthen national regulatory authorities to be able to ensure the good manufacturing, production, to make sure that vaccines are safe and effective within countries and to evaluate those data. We know to date that currently Africa only produces about 1% of the vaccine that it needs. And again, because this can be done, but scaling this up, the tech transfer, having the facilities, having the ability with the regulatory authorities, all of this takes time to develop and cannot be done overnight. Recently, WHO has announced in February of this year that 6 African countries, that will be Egypt, Kenya, Nigeria, Senegal, South Africa, and Tunisia, will be the first countries to be assisted by the global mRNA hub, which is based in South Africa, to produce vaccines. And so we'll be scaling up local manufacturing for COVID-19. What we do know as well is that vaccines produced in Africa through the current plans that are moving forward will still be owned by pharmaceutical companies, which will control the pricing. So again, thinking about vaccine equity and getting it to the most vulnerable, this will still be an issue in terms of what the cost of the vaccine will be, even with the current manufacturing in place. And I want to wrap up by bringing us a little bit in thinking about how Dr. Paul Farmer, who has done much work in health equity and has left quite a strong legacy for all of us in this work, about what he did in thinking about equity in HIV and antiretrovirals. In 2002, millions of people in low and middle income countries, particularly in Africa, were dying from HIV and AIDS due to lack of access to the most effective HIV antiretrovirals. And these antiretrovirals had been available in the global north starting in 1996. And the previous, one of the previous USAID administrators in 2001 noted if we had HIV medicines for Africa today, we could not distribute them because Africans do not know what watches and clocks are. And I think this just takes us back to 2001 when this statement was made. Dr. Paul Farmer did not believe in this at all. And if we think about it today, I mean, it's totally irrelevant for today's environment and the sentiment. So in 1999, working in Haiti, he worked to bring in the most effective antiretroviral to colonies in Haiti using a system of accompagners. And again, this is about working with the community, the engagement from the community. And there was outreach for HIV testing, prevention, and visiting the homes of those who were living with HIV and ensuring that antiretrovirals could be brought to these people in the community. And he did this through the solutions that were created at the local level with community engagement. And this led to, over the years, both the President's Emergency Plan for AIDS Relief and the Global Fund providing effective HIV medications for LMICs. So again, bringing the equitable access to life-saving drugs around the world. So in closing, thinking about this a little bit, I could talk about Ebola vaccine and access and how that vaccine development stalled for nearly 20 years until the most recent West Africa outbreaks that quickly accelerated some of the progress there, which has led now to a licensed Ebola vaccines. But we do know as well, for other vaccines, what will be the future about how we do this, and that vaccines we may need for future pandemics. And I want to close by just also noting and thinking about vaccine equity and health system resilience work, that during the pandemic, 23 million children missed out on their basic childhood immunizations through the routine health services because of COVID-19. And this number was much higher over the previous year, and since the highest number since 2009, when more than 3.7 million children were not vaccinated. So again, as we think about catching these children up with their routine immunizations, we have to think about the equitable distribution of these and how we will do that. Because if not, we will see large outbreaks of vaccine preventable diseases around the world as well. So thank you. I'll stop there, and I look forward to hearing from the discussants.
Thank you so much for this sort of thought-provoking journey, Rebecca. Before turning to our discussants, I wanted to ask just one question. And, you brought up the sobering reminder and example of our lag in, providing effective HIV treatments. And it seems that, we didn't learn from that in terms of being able to rapidly break down the barriers for COVID vaccine distribution. And I wondered, how hopeful are you for creating structures through which we're able to do this more rapidly for, future health crises, particularly future pandemics? And in particular, the pandemic treaty, it comes to mind, which of course is a work in progress and promises to feature heavily in the upcoming World Health Assembly. So I wonder what your thoughts and hopes might be for that.
Thank you for that question, Rachel. I think this is one thing, is that we must continue to push forward on this and be persistent. The window is now if we're going to do this while we're still seeing COVID-19. We know quickly that attention and focus can change with time, but I think this is important with the pandemic treaty of trying to codify some of this as well, to hold governments accountable. Tomorrow, there will be a world summit on COVID-19 to look at further donations to be able to support the actual delivery of vaccines in countries. And I think the more and more that we talk about this outside of the health sector with people of influence, with leaders around the world, be it of a government or a global leader, this is so important to do this. And am I hopeful on this? I think, we stood up some institutions thinking about COVAX, for example, and what is the future of that? What is the need to think about how can that be transformed from a one focused disease to what else could be done in the future? But I think the longer term planning that has always been put off is how do we make sure vaccines can be managed, and vaccines, but diagnostics too, be manufactured where they are needed, and how do we support that environment? And that's a tough road to go down, but it's important that we do and that we bring all the key players to that. So I am hopeful, but it will take a lot of work and a lot of focus on this and actually learning from this to take this forward.
Thank you. Well, this is a perfect moment to introduce a couple of other key players and organizations that have been engaging with vaccine efforts. I'm going to briefly introduce both of our discussants today and then hand it over for comments from them. So we have Ms. Amanda Bolster, who serves as Associate Director of Development and Partnerships for the Respiratory Virus Prevention Programs at the Task Force for Global Health. In this role, she supports the partnership, communications and strategy work of the Partnership for Influenza Vaccine Introduction, PIVI, and Ready to Respond, a public-private partnership committed to augmenting low and middle income countries' readiness to respond to influenza and emerging respiratory viral pandemics. So with 20 years of branding and communications experience in the nonprofit and corporate sectors, Amanda's goal is to cultivate the strategic and impactful partnerships needed to create systems change at the community, national, and global level. Our second discussant is Dr. Stephanie Adams. Dr. Adams is Managing Director of the Center for Global Health Innovations Office of Health Equity and Crisis Coordination. She has spent the last 2 years overseeing CGHI's community outreach programs to address COVID-19 and build community trust while addressing health equity. Stephanie has over 20 years of experience in the nonprofit, biotech, and pharmaceutical industries. And prior to joining CGHI, she served as a consultant with King & Spalding's intellectual property counseling practice. Stephanie's expertise extends across a wide range of biotechnology areas, including molecular biology, neuroscience, immunology, and vaccines. So with these couple of powerhouses joining us, I'm going to hand it over to Amanda for her comments.
Yeah, thanks so much. And thanks everybody for joining. And I do want to say I had prepared remarks, of course, but listening to Dr. Martin, I'm kind of shifting gears a little bit. So if I'm looking down, it's because I was writing notes while she was talking. So as Rachel said, I work with the Task Force for Global Health, which, if you aren't familiar, we were founded nearly 40 years ago with the goal of advancing health equity. And we work with partners in more than 150 countries to eliminate diseases, ensure access to vaccines and essential medicines, and strengthen health systems to protect populations. I work specifically with our respiratory virus prevention programs, which obviously is now COVID and was only influenza, but we've grown. And I work in the development and partnership space. And this is incredibly important because, as Rebecca was sharing earlier, this is a long-term investment, right? And we need to get everybody engaged in the important work of building up systems in countries. There's been hundreds of millions of dollars poured into vaccine development, which is amazing, but getting countries ready to receive and deploy vaccines is a critical part of this. And that's what the task force does. You may have heard, and people have shared the thought that vaccines don't save lives, vaccinations do. That's exactly what we're working on. So I wanted to talk a little bit about what we do with both our flu programming and our influenza programming. So as Rebecca stated earlier, the low and middle income country vaccination rates really are lagging far behind those of higher income countries. And in Africa, fewer than 17% of the population has been fully vaccinated. But we're at this point where we have enough vaccine, just not enough demand. And John Kingasong, who now is heading PEPFAR and a lot of other things, he has a very long new title, but as the director of the Africa CDC, shared that the main challenge in vaccinating Africans was not lack of vaccine, but logistics and vaccine hesitancy. And so there are a lot of barriers to countries being able to deploy vaccines. And one that we may not have thought about a lot in the US is adult vaccination programs, because adults around the world are not accustomed to getting vaccinated. They're not accustomed to going to clinics. And so this is something that we work on both with our flu programming and with our COVID programming. So one of the things that's happened, which we knew about pre-COVID, is that flu programming really sets the stage for a stable vaccine delivery system in countries. You're able to test all of the systems and vaccine delivery systems that are needed in terms of healthcare worker training, regulatory issues, making sure that risk groups are assessed, that sort of thing. We know that during the 2009 H1N1 pandemic, countries that had flu programs were faster to deploy vaccines. Healthcare workers who had seasonal vaccinations were readier to receive pandemic vaccines, so they stayed safe, their patients stayed safe. The other thing that we're learning now through our partners with PIVI, the Partnership for Influenza Vaccine Introduction, is that they are seeing a real correlation between the strength of their flu program and their ability to deploy COVID vaccine. So all of those things that they had been working on with flu programs, training healthcare workers, assessing risk populations, they're putting to work with COVID as well. This is one of the reasons that we were able to launch our COVID work, which is the COVID Vaccine Implementation Program, or COVID, where we do very similar work with country partners from introduction of vaccine through implementation, evaluation. We do financial grants, we do direct technical assistance. All of this is with the goal of establishing, first and foremost, COVID vaccination, but a sustainable adult immunization program. And we don't know how long, none of us knows how long COVID-19 is going to be around. It seems like it's going to be around for a long time. We don't know what the vaccination staging will be, how often people will need to be vaccinated. We do know that flu comes back year after year after year. And so with annual flu programs, we're able to keep the systems, those vaccination systems, warmed, primed, and ready, while also keeping communities safe from flu. We're able to then do that with COVID as well. And we think that we can get countries readier to sustain future pandemics because there will be more of them with these programs. So as a global community, we've done a lot. We know that there's still a lot left to be done, but also know that adult vaccination programs are really key to ensuring equitable response to current and future pandemics. And I'll drop off there because I know we have more people to speak and questions and answers. Thank you.
Thanks so much, Amanda. And Stephanie, I'll hand over to you now.
Thank you. I'm not sure if I can come off video. Let's see. Are you able to
Hi, Stephanie, can you try again to come up?
see all of you?
Works
Can you
now.
hear me? Can you hear me?
Fabulous. We hear and see you now. You are
Okay.
good to go.
Perfect. Thank you. Sorry about that. Thank you for inviting me to join, and thanks to the preceding speakers for teeing up, sharing amazing information on global outreach. I'd like to share a little bit about what we've been doing since our start. Our division started in response to the COVID-19 pandemic and really grew organically, mostly domestically, and looking for models to scale globally as we move forward in our organization and with this pandemic. So, and as Dr. Martin alluded to, my background, and thank you as well, my background is in intellectual property and tech transfer as well, which I won't address specifically here, but just want to say that, it's an incredibly important aspect of this globally, and happy to be involved in further conversations. I know there was a lot of work done in AIDS, and hopefully that can be transferable to removing those barriers as we hope to distribute COVID vaccines more globally. So just briefly, we are a relatively new entity, the Center for Global Health Innovation, and we have 4 divisions, and I am the managing director for the Office of Health Equity and Crisis Coordination. And I won't read all this to you, but just to give you a sense of the breadth of the programs and the focus that we've developed, again, over the past 2 years, as we really stood up in response to the pandemic. We very much grew to incorporate health equity in our work. Again, very organically, as an organization that was funded very quickly by the CDC Foundation and Microsoft to start up and address what we could and act among our competencies as staff to help solve obviously the biggest crisis and pandemic we've seen in over 100 years in this country. And very quickly, our efforts shifted to focus on equitable vaccine distribution of the COVID vaccine. And we've been working to create innovative models. How can we, again, begin domestically, but really strive to develop innovative models to then scale this work globally? Because as we've heard, vaccine hesitancy, we're really in a pandemic of misinformation as well as a pandemic of the disease itself. As Amanda shared, in Africa, there is ample supply at the moment, but getting shots in arms is the whole next step. And that's exactly the work that we've really grown to focus on. We have a large number of private sector partners, particularly in the technology space. And so all of our work is guided by how can we effectively reach into communities, restore trust in the public health and medical systems, and work alongside our private sector partners to develop models that would hopefully scale this more efficiently globally. Most large corporations, as you all are aware, we have their attention right now. They're very focused on developing health equity programs that make sense for them to help philanthropically, but also for them to help in a business sense, and looking and striving for ways to incorporate health equity initiatives within their business plans. We started early on really forming community collaboratives that are really essential. Those of you, many of you that do work globally really know the importance of these type of community programs. We haven't seen as much need for that in this country, and our work really focused on NGOs, schools as trusted messengers within communities that we could work in, as well as faith leaders as trusted messengers within the United States to advance trust in COVID vaccination. So that was really where we started a couple of years ago. We grew that into developing certain projects focused on vaccine equity. The first of those was a priority-based use of allocated vaccine estimator. This work was led by Dr. Rob Bryman, who is at Emory. And as you can see in each of these projects, and we grew them quite nicely, this is sort of a timeline. First was PAVE, then COVID, then VET. How do we bring together multiple sectors, government, private industry, national public health organizations to really collaborate and work together to advance health equity. The PAVE calculator is it's a web-based calculator to help public health officials determine who in their area or their jurisdiction is most at risk for COVID complications, and then distribute vaccines specifically to those populations first. We also worked on a project called COVIED, which is the COVID Vaccine Information Equity and Demand Creation Project. So stepping forward in time beyond 2020, it was obvious to, I'm sure, all of you and us that the inequalities in vaccine messaging and spread of misinformation in under-resourced populations was dominant and was creating its own pandemic. What types of communication platforms and how do we reach into those communities to develop effective communications? In this country, we see that certain types of messaging will work well in one community and really not work well in another. For example, is it best for a public health official or a medical professional to stand up in front of a community and try to combat the misinformation? Or is it better perhaps for a faith leader? In different communities across the country, we see different needs for trusted messengers. And then lastly, and the project that we're scaling and growing right now is actually funded by HRSA, and we are looking to develop effective models to hire and deploy rapidly community health workers across 7 states right now. We've hired over 120 full and part-time community health workers in some of the most under-resourced areas that still exhibit COVID vaccine rates in this country, at least below 25 or even 30% of their populations. Again, but we are working with universities, public health, national public health organizations, as well as our corporate partners to work alongside of us and develop effective communication means. How can we respond quickly to needs on the ground as a pandemic unfolds and as we work to restore trust? Technology can help us do that, and we're hoping we'll be able to update you in the next few months as we test some of these pilots and use technology to effectively have communications come up to really equitably distribute in that last mile and really convincing those that are hesitant to get shots in arms. And lastly, our organization is working on a special project called Becoming Better Ancestors. We are producing and will promote multiple learning tools to document the history and lessons learned from smallpox eradication and demonstrate their relevance to today's global health problems. I'll drop the URL in the chat, but the curriculum includes a programmatic introduction and 9 episodes to focus on these 9 lessons that can really work to transform public health. And it's really for medical, nursing, public health students, practitioners, government policy leaders to really take a look at and really understand what we learned during the eradication of smallpox and other public health crises, and share that and deploy these teachings as we look to transform global health. And as number 9 states here, identify the best solutions to move us closer to global health equity and global vaccine equity. So thank you. I know that we need to have some time for questions, so I'll stop there.
Fantastic. Thank you so much, Stephanie, and to Amanda, you as well. This is, so exciting and hopeful to see, excellent programming that is really growing and taking off during this time to address these pressing challenges. And something that a common thread that I'm really noticing across Rebecca's presentation as well as our 2 discussants is really this focus on sustainable programming and cross-sector collaboration. And so with that in mind, I'd like to pose just a sort of final question to each of you, which is, how do we get the balance right? I'm very mindful that, all of us are sitting, living and working. We're global health here in Georgia. We're in a high income country working in high income institutions. And so how can we get the balance right of doing this sustainable programming work while foregrounding the leadership and, priorities of our partners in the global South? So I don't know if Rebecca, you would mind kicking us off?
Sure. No, thank you for that. And again, wonderful remarks by both of the panelists too. I think your question is really very important. And what we saw with COVID-19 vaccine is when the African countries could not get access to vaccine through COVAX, again, because of delays and not being able to meet it, the leaders of African countries through the Africa Union came together and met with manufacturers and said, we have money, we want to buy vaccine. And I think this is where, to your point, is we need to get behind and we need to support the leaders in their efforts to do this and how we can come together to do this. And I think that's the important part, is having the leadership take the lead on that. And as we heard from one of the participants in the discussion today from Cameroon, again, with the vaccine hesitancy and thinking about the uptake of vaccine once vaccine is available, we have seen countries, Democratic Republic of Congo too, where vaccine uptake has been very low. And again, it's like, how do we get behind the communities? How do we get behind the influencers to figure out what is needed and work with them and support their efforts in making sure there's access to data, information, and that there's global partnerships to support their efforts.
Excellent, thank you. Amanda, do you want to?
Yeah, but I agree totally with that. I had written down on my own, listening to partners. We work extensively with countries. And so making sure that we are listening to country partners as they tell us what they need, but not only what they need, we need to always be mindful about integrating it into their health systems. While COVID appears to be vertical because it's one disease, it's really not. The ability we have now to be able to strengthen health systems overall, for just readiness for future pandemics, for other diseases, is remarkable. And as I said, I think before, or maybe I just thought it, we don't want to stay in this cycle of panic and neglect that people have talked about in terms of pandemic response. You can't build and respond to pandemics at the same time. So if we're building it, responding now, but we're building for the future, countries will be in a much better place. Thanks.
Excellent, thank you. And Stephanie?
Yeah, I would just echo, especially Rebecca's comments about data and really being able to share with leadership of countries or whoever the appropriate leadership is, actionable data with those decision makers, and that's a role that we can play as a country and take that. We haven't seen real transparency and real ability to share data on different demographics, on different risk patterns very nimbly right now. And that's definitely something that we're striving to look towards as well.
Fantastic. Well, thank you so much to each of our speakers for helping kind of introduce us to and grapple with some of these huge challenges that we have faced and some of the opportunities and solutions that we can look to moving forward. I'm going to hand it now to my Women in Global Health Georgia colleague, Dr. Subhasri Narasimhan, to close us out for today.
Yeah, thank you so much, Rachel. I just wanted to thank all of the speakers, discussants, and participants for today. We'd like you all to, keep in touch with each other, keep asking questions, and also please look out for our fall WGH events. We've had a great time speaking with you. Thank you so much.